Hello everyone. So now we have a 40-year-old man who comes to you due to 2 days history of retrosternal pain chest. Short history. Pain with swallowing and epigastric burning. Pain is severe. Patient is afraid of swallow food. Never had similar problem before. And he is taking drug like furosemide, carvedilol, spironolactone, lisinopril, potassium chloride also. BP is normal, soft hollow systolic murmur is there. ECG is normal. Endoscopy reveals circumferential deep ulceration with relatively normal surrounding mucosa at the middle third of the esophagus. Most likely diagnosis is, well, it's a beautiful question. Answer is pill-induced esophagitis. Why this? Why not others? Patient has abrupt onset of retrosternal pain chest with odynophagia. Odynophagia means painful swallowing, and we know very well it's only 2 days history is there. This is suggestive of medication-induced esophagitis, so-called pill esophagitis. This is due to direct effect of certain medication on the esophageal mucosa. Let us see what are the medication which commonly can lead to tetracycline, potassium chloride, NSAID, and biphosphorate. And we know very well this patient is taking potassium chloride tablet. This could be a reason why the patient is having this problem. Patients usually do not have any esophageal diseases, although pill esophagitis can be worse in those with concurrent esophageal reflux disease, so-called GERD. Now, when we talk about pill esophagitis, symptoms include sudden onset of odynophagia, painful swallowing, and retrosternal pain chest. As I told you, patient had retrosternal pain chest, pain with swallowing, and epigastric burning. This is severe, and patient is afraid of swallowing of the food. This is what is given in the question also. It's the most common in the mid-esophagus. This is due to compression by the aortic arch and a large left atrium. So diagnosis is usually made clinically but can be confirmed on endoscopy, which shows discrete ulcer with relatively normal appearing surrounding mucosa. And if you look in endoscopy finding what we got in our patient, endoscopy reveals circumferential deep ulceration with relatively normal surrounding mucosa at the mid-third of the esophagus, which is the classical finding we get in pill-induced esophagitis. Now look into this. This is the pill esophagitis. Treatment includes stopping the offending medication to prevent further injury. Now let's look into other options, option A and C. Candida esophagitis and viral esophagitis. Endoscopy in Candida esophagitis is characterized by white plaque, and most patients do have oral thrush also. That means oral candidiasis also. Ulcerative lesion is seen in esophagitis due to herpes simplex. Okay. You get vesicle and round ovoid ulcer, or in CMV, large linear ulcer are there. The conditions are most common in immunocompromised patients. Now look into this. In herpes simplex esophagitis, you can see this type of finding we get it. Okay, and if you take a biopsy piece, you get, look into this, you get nuclear inclusion body are seen in these patients. If you take a histopathology in herpes, look into this, same you are getting inclusion. Oral thrush, oh, just see, which shows candidiasis. Now look into this, Candida esophagitis, so many these plaques are there. CMV, solitary large ulcer, all are classical finding that we get in these patients. Now I have a question for you. Corrugated appearance of esophagus in endoscopy is seen in which condition? Stop the video, write down the answer. This is seen in eosinophilic esophagitis. Look, the classical corrugated appearance is seen. Let's talk about herpes simplex esophagitis. Multiple ulcers become confluent like a map. Multiple ulcers are there. And ultimately they confluent like this, like a map. Like in this case also you can see. So since there are multiple ulcers, they can extend to a great area covering the esophageal. Okay. Well, let's look into other option. Diffuse esophageal spasm. It is characterized by uncoordinated simultaneous contraction of the esophagus. Patients typically have recurrent episode of liquid and solid dysphagia, to both point to be noted, and there may be pain chest also. Look into this. When you are seeing classical barium studies, this is the diffuse esophageal spasm. Now let's talk about esophageal reflux disease, gastroesophageal reflux disease, so-called GERD. Typically occurs recurrent or persistent burning pain in the upper abdomen and chest. Symptoms are worse following large meals or certain food like chocolate or peppermint. When lying down, symptoms are usually subacute to chronic rather than abrupt. Remember, in our case, these are only 2 days history. So this cannot be a case of GERD. Endoscopy, what you say, this is classical finding that we see, that the finding what we get in esophageal reflux disease. Golden line to remember, esophagitis is due to direct effect of certain medication on the esophageal mucosa. Common causes include tetracycline, potassium chloride, biphosphonate, and NSAID is one of the most common causes. Patient experience sudden onset of odynophagia and retrosternal pain, most common in the mid-esophagus due to compression by the aortic arch and the enlarged left atrium. Thank you very much.